Okay, all right. So the ankle can be quite bony. So first tip, plenty of jelly. Okay. I would normally sit with right in front of the patient here, with his leg hanging off the end this way. But just for purposes of good camera angles, we're going to do it a little bit differently. So the first thing to tell you about this is we want to be looking somewhere, kind of draw an imaginary diagonal line from the medial malleolus to the sort of posterior tip of the calcaneus, and somewhere in that angle. So it's a diagonal angle once you found the tip of the bone. Of course, you've got to find your, make sure your probe's in the right place. So the best way to do that is to just flip the tip, flip the end. Okay, so I want to see bone on the right-hand side of the picture. Okay, so do you want to just maybe mark out where the tip of the malleolus is there for me, chap?
Yeah. So tibial malleolus is here.
So right at the bottom end of the malleolus, I've just got that in the picture. Okay, and then immediately the arrow there is showing you the posterior tibial tendon. Look how big it is. Real big, nice, meaty structure. Of course, we're looking at it in transverse axis here. So if you cut a sausage in half and you look at the end of it, that's the view that we're looking at. Okay, there are several ligaments and also the deltoid complex and a lot of other stuff. We're not going to cover that today in this program. That's for a bit more advanced scanning techniques. So there is more shows on the way with that in future, but we'll stick with what's basic. So okay, there's your tibialis posterior. Then we want to see a little bit of flexor tendon here. We go a bit further down, and of course it does depend on the size and the footprint of your probe. A bit fiddly, isn't it?
Right.
Okay, and then you can just make out here your you can see your artery pulsing away right here. You see the movement in it? Yeah, so we can put our colour box on there and have a little look at blood flow.
Just bear with me, find me.
So if you click your CFM button, you'll be able to see the flow in that, and you'll also see, I was doing this kind of on purpose. Can you see I've got way too much pressure on this? So I've squished the artery there, but at the same time I'm squishing plenty of other structures. So if I just release my pressure, now can you see how many structures? You can see a neurovascular bundle. All right, so you can see what a difference that makes. I'm applying very little pressure, but I've completely squished everything out of the way. So it's just a tip for everybody who's just starting. You know, it's really easy to miss stuff if you haven't got quite, if you've got a little bit too much pressure on there. And I'm really not pressing very hard at all. There's very, very minimal pressure there. And look how much I've reduced the quality of our image. Yeah, so let's just go back. I'm literally just using the weight of the probe here. Yeah, so very, very gentle. You can see I'm holding it more like a pencil. Yeah, you can use your fifth finger here to guide yourself around the bony contours. But that's the kind of picture you want, depending on the size and footprint. Ideally, you get everything in the picture. And if we shrink the picture down, we probably will get a little bit more. So we're quite deep here. Let's just go a bit more superficial. And then you can start to see the neurovascular bundle and the tendons all together. Is that kind of clear for everyone to see?
I'm seeing it nice and clear. I'll just see if I get any nod to the head on camera.
Just for your information, if you just go back a second, Abid, I'll just point out, I won't go into this in too much detail, but just go back a bit more. I'll say this here is the medial deltoid ligament here. We've got a superficial and a deep component, but just be aware that that's the deltoid here, and then you can go through that at another more advanced webinar.
Can I just point out the flexor tendon in case they're not quite picking that up?
So yeah, this would be the digitorum. We've got tib post, flexor digitorum, and then flexor hallucis is here. And the reason why flexor hallucis is dark while your flexor digitorum is bright is because it's taken a slightly different course. So you'll find that when this one's bright, your digitorum will be dark, and vice versa. When your digitorum is dark, your flexor hallucis will be bright.
Of course, you've got the layers of sort of tissue above that. So if we go right to the top of the screen, you can see a little bit of a subcutaneous tissue there, some ripples in it, and then you're down to the neurovascular bundle and the tendons. So just out of interest, can we measure the depth there between the tissue and the structures?
Yeah. So if when you're measuring depth like this, what you need to do is take the pressure right off, so you just release, so you're barely touching the skin. And then when you've done that, freeze the image, and then measure. Here's my measuring tool. Caliper. So then just measure. If you're measuring just the thickness here, like that. So 2.7. And if I unfreeze now, and Abid adds a little bit of pressure, that will probably squash that down to a lot less. Let's caliper. See, and also be careful where you measure because it'll change.
So you see how subtle the different layers of tissues are. The sort of a grey scale in there. It's very, very subtle.
Yeah.
Should we just, how about if you make the image a bit darker there, Adrian?
Yeah.
Just to show the guys what that would look like. Yeah, so we put it up quite bright just so you can see the structures a bit easier on the television, but sometimes it's better to go a bit darker. You can sometimes actually pick up more stuff. So you can see I'm just moving up along. I'm not staying in a straight line. I'm following the contour of where those structures would be. So I'm kind of angling my probe up and around, so I can even pick these up higher up the tib if I wanted to. I can follow it. You can see the tib ant here, right up against butting up against the tibia, and you can follow that as high as you like, really. You know, we'll keep it to the sort of ankle region. And if you see, I'll just transverse straight down with it. I can keep that structure in the frame. See a bit of retinaculum just over the top there. You see this retinaculum just appearing, and then a bit further down your neurovascular bundle. So really what you're looking for, and actually interestingly, we often would you measure tib post here for your initial examination? I mean, they're also different, they're also varied, aren't they, depending on the size, weight, age of the person. You see some really thin ones. Adrian's got a very nice chunky looking one. It's quite easy to pick up, but some are much, much smaller and thinner. But the key tip there is get bone in the view. Make sure you can see plenty of bone, and then it won't be long before you pick up these structures, and then you just got to follow them down around. So you see I'm following, so now I've gone past the malleolus, I'm heading down the foot. I've got the tib post here in view. So get that centrally in your screen and keep that in the view. And then it starts to disappear off. And then come back a little bit. Sometimes you'll lose it, so you just go back to where you saw it. Follow it down. It might need to go a bit brighter there, perhaps.
So what I do here
is broadening and
is
flattening.
because the tib post effectively splays out and attaches in various locations, I tend to go long section about here and follow it onto the navicular. It's a little bit easier to trace than it is in transverse.
So you can go long here and follow it from the insertion point back up, or potentially you can go into long axis up here if you like. So we'll do it where Adrian suggests. So about here, we'll get the tendon in the middle of the screen, as big or as small as you like the image, so it's easy for you to pick up. And then we just try to start to spin on it. Okay, so just hold it in view here, very light pressure, and then start to turn your probe. You'll start to see it, and then start to see it disappearing off, and then it should start to straighten out. And then you just got to find the two ends. So you've got to angle and clock face your probe a little bit here. So can you see my movement? I've got this point because I've got the tendon in view on the right hand side of the screen. Yeah, but not quite in view at the distal end. So I'm just going to clock face my probe a little bit, and you can see how the fibres are broadening and flattening out here. And we're just going to keep on that structure and follow it down to our Insertion point, you can see the bone appearing. It just start to lose it a little bit, but you can still see the tendon, and there it goes attaching onto the navicular. And then, of course, you could follow it under the navicular as it courses that way and see if you can pick it up, but you can get a bit fiddly there.
So these are where this is dark, and these fibres are going down. That's why you're losing it here a little bit, because they're splaying down and under and attaching somewhere underneath.
We just follow back up again, so we stay on the tib post tendon. Now I'm getting back to near the bone, so you start to see a bit of shadowing perhaps here as it bounces, the signal bounces off the bone, and then you've got to kind of twist your probe to keep on it. So, you know, you just got to know your anatomy, and look how we can just twist ourselves around the malleolus here, and we've still got tib post in view. Yeah, and then we can just clear our image up from one end to the other end. What's that bit there?
Let's start picking holes in the bone already.
What's this there? You see this, guys? You see this little apparent sort of defect in the bony cortex and a couple of little white flecks around there. Is that sitting in the actual tendon?
I don't know.
That's a bit hard to...
If I saw this probably elsewhere, I'd probably call this an erosion, because an erosion is like an where the bone just get an eating away defect. I don't think it is an erosion, but it's an unusual place to get an erosion, I suppose. But
yeah.
But that's essentially what an erosion would look like. So if you saw this on the metacarpal, like a little divot like that, you've got to start thinking of erosion.
Very interesting little feature there.
Yeah.
Not what we wanted to show you, but interesting. Yeah, the things you'll pick up along the way, and the point is, you know, is it clinically significant or not?
Let me just put a bit of colour on that. Oh, where's my PDF? Oh, there it is. Oops. Yeah, I don't know. So if you do get elsewhere, if you're looking at that, you see there's an erosion, it's always worth putting the Doppler on, see if there's any sort of colour flow within that erosion, because that can mean that it's actually a sort of an active erosional defect, which is
bit of a worrying feature.
Yeah, the rheumatologists want to get on those quite quickly.
You see them in rheumatoid ankles a lot. Divots and features, do you think?
Well, for rheumatology, for me, they just tend to come as wrists and hands, really.
Should we spin on it and see if we can see anything?
Yeah. See, that's the other thing, actually. If you see it in two planes, then it's definitely there. And it does look like it is there, doesn't it?
There's a little defect. You see that little...
Yeah, where's my arrow gone?
Showing on these.
So it's just here, I think.
Yeah, it looks like a little hole in the bone, doesn't it?
Yeah.
Interesting. So what's that? The best thing to do with that is get an X-ray.
Abid?
Yes?
That erosion that you've just shown there, are there any features that would include or exclude infection?
I'm not so sure that it is an erosion, Steve, but...
Okay.
No, you can't really tell infection, really, but you could put the Doppler on if you can get some sort of active inflammatory response from the Doppler, but I wouldn't be able to tell whether it's infection.
Just getting back to the tendon, then you can see the tibia right at the bottom, the bright white line. You can see I'm following the tendon very nicely. So where are we now? We're about a third of the way up the shin. Okay, now you can see it's a lot more deeper. This the soft tissue overlying on the top. You can see the fatty tissue, adipose tissue. Adrian's got. But normally you're doing the fat jokes at this stage, aren't you?
Yeah, I can't talk now.
Okay, so and you just want to make sure you keep a bit of bone in the picture. But of course, it's going to get deeper and deeper now, and it's going to start to lose signal because we're penetrating through a lot of layers.
He's getting his own back now.
Okay, so going back to our structure, so do you want to just point out the tibial nerve there for me, please?
Yeah, let's just bring the... Oh, focus.
So all those ankle blockers out there.
So where are we? Is it here maybe? Yeah, there it is. There you go. You see the little. I mean, I always call it a polycystic ovary, but if you've not seen a polycystic ovary on ultrasound, you won't know. But essentially, it looks like this.
You see what I'm doing? I'm just applying a little bit of finger pressure around here. So I'm trying to landmark where I am or where I want to go potentially with a needle. Try and get to the nerve. So I don't want to put it there. You see, I'm going right into the blood vessel. Probably want to do it more in long axis anyway, but yeah, you can do it there. All right, so let's go back to our tendon for a moment. Just make sure everyone's happy with that, because of course you're going to look at loads of these, all the podiatrists out there. You're going to look at tons and tons of these. A defect, just while we're on the subject, if you look at the main body of the tendon there again, you generally tend to get like a C-shaped tear in there. If there's a tear, intrasubstance is probably the most common. You know, so it's a tear within the internal fibres. That's probably the most common I've seen. How about yourself, Adrian?
Yeah, indeed.
Perineals too, tend to see that most commonly.
Yeah.
Very rarely just a linear tear in isolation. Yeah, and horizontal tear. I mean, you know, high velocity trauma and stuff. Perhaps. So I've not yet seen a completely ruptured one.
No.
And you know, you see tib post dysfunction, for example. I mean, you see somebody with one foot that's normal structure, and then the other foot looks pretty much pes planus. And you'd expect to see some, you know, they've had obvious symptoms of a posterior tibial tendon dysfunction. And so you get your ultrasound on there and you have a good look around, and you can't always see anything really wrong with it. You know, so it's hard to see if a tendon's been overstretched.
Yeah.
Yeah, and because essentially tib post is a overstretching of the tendon. And so it can have quite normal sonographic features to it, because unless it's torn or ripped or become tendinopathic, you know, you're not going to see any real difference in there. It may be thinner, but you know, if you compare it with the other one, you might find the main the thickness of it is altered because it's become overstretched. But otherwise, interestingly, you know, a lot that you'd send for a tib post, you won't really get anything reported back if there's no other features with it. All right, so there we go with our structure. So again, we can go into a long axis on these if we wish. We can pick up our, if you want to put your colour flow on there in a second.
Oh, sorry. So also, when you're using the colour flow, if you don't need to see a large area, reduce your box size just by clicking the button, and it will change the size of the box here. And that it'll do, because you have your box too open, it'll reduce your frame rate. It'll get all pixelated and slow your moving pictures down. So bring your box to the appropriate size and just interrogate that area, and you won't lose your frame rate. Well, you'll lose it a bit, but not a lot.
Okay. Anything else you want to do there? That's enough time on that for the moment. Let's move on to the anterior ankle. Do you want to stretch up for a second, Adrian?
Yes.
I will reapply the coupling jelly. Okay, so we're going to start on the anterior ankle now. Of course, it's quite broad, so you're maybe not going to get the full picture. We'll start here in transverse axis. So again, just make sure you know which side of the probe is which. I'm just going to apply it right here over the sort of lower third of the tibia and just above maybe the line of the malleoli. So palpate your malleoli and maybe just start your examination just slightly above. So immediately you can see in the frame, if we look right down at the bottom, you can see the tibia. Actually, that's your ankle joint.
Yeah.
Let's start here. Yeah, so here's the tibia, nice sort of rounded shape, and you can see I'm just angling around it because of course this is curved in the leg and our probe is flat. So you're going to need to manipulate your probe a fair bit around here. So again, we're just following the contour of it. Here we have, do you want to just point out the tib amp maybe?
Yeah, so it's this one, I think.
That's the maybe. So you see a nice cross section of it. So you've got a normal mild trace of fluid around it. Yeah, a little black sort of halo all around the tendon, and then you can see the internal fibres, internal structures. So again, if you're suspecting any tears, it's good to look at it in transverse first of all. We can see how far down I am in the foot now. I've gone past the ankle. I can still stay on it, and if I wanted to, I can follow it to its insertion. You see it broadening out and flattening out now as we go over the medial aspect and head over to the navicular area. So again, we'll probably go long axis here, but let's follow that back up again. Back up the leg, and watch how I have to trace a little bit to keep it in the middle of the picture. And you've got the tibia back in view. And we'll just look at it as we pass over the ankle mortise, because we just did that a second ago. And we'll just pick that up for you so you can see the where's your ankle gone? There it is. Right. And what's this we're seeing over here is a blood vessel there.
This one?
Yeah, let's see that. What's that? Anterior tibial artery.
Yeah.
So come a bit medially here, look, and I'm only able to keep, can't keep the full picture in the probe. So I'm going to go a bit more anterior. We've just gone past the tibant now. So let's look at the extensor complex. So I'm going to go a bit higher up the leg again. So we'll come around a little bit now. Should start to pick up the extensor tendon slips. You can see 1, 2, 3 there. And the dorsalis, this is artery there too. Do you want to just point out the tendons above? A bit of muscle belly. And then
so I think this will be hallucis here, maybe.
Yeah, yeah. You see these guys are quite faint in there. Extensor hallucis, extensor dig.
So dig is going to be around here somewhere.
You can see quite a bit of muscle here. Look how low down we are in the leg. We were looking at this a little earlier, weren't we?
Yeah.
There's a lot of muscle there on that sort of anterolateral aspect just before you get to the malleolus. And we're trying to figure out what do we call that when we earlier? I thought that would be the muscle belly of
digitorum, maybe.
Yeah, extensor dig. Okay, so bit of fiddle. Okay, so get your main tendons in the view. You can see the artery pulsing away. Trying to keep the tibia in the picture. And we're going to come down the ankle now. And we're just going to see the talar head appearing. Can you see at the bottom of the picture here? So trying to give you a good broad view of it. So there's the head of the talus and the hyaline cartilage ankle mortise. You see the black line above. So look how deep we're penetrating. We've gone past the tendons. You can see the above in the picture. There's a bit of soft tissue retinaculum stuff. Got a nice artery. You know, look at the quality you're getting in real time. And then you're into the ankle mortise here, really. And so there's the square sort of square head, really, of the talus, more or less. And again, we've got a fairly small footprint probe here for a full ankle examination, but you can make do. You can make do because look how we can just scroll around. So I'm staying in a nice straight line and I'm just interrogating every corner of this sort of talar dome area. What kind of features do you see in there, Adrian, in transverse section? Erosions again, some sort of...
Yeah, osteophytes on these corner bits here. You can get obviously gout and osteocalcinosis. What's it? CCPD.
Osteochondral OCD?
No, oh, do you know what? I've got it now. But it says that you can pick up gout here, the cartilage, if you've got like a double contour sign. But I don't see it very often here. I can see it more in the big toe joint and things like that.
Yeah, it's a lot of detail, really. A lot of detail there. It looks like you're talking out your artery there, Adrian.
What, sorry?
That's his pulsing in your sorry, sonography joke. Terrible one. Okay, and then we're just going to keep that in the view. We're going to keep coming down. So we're passing over the ankle mortise now. and now we're coming down onto the sort of beak of the talar head. And that's kind of as much as you need to go, really. So we started at the upper third, lower third of the tibia, found our tendon structures, and you can individually pick them up and follow them, and it is really, really good practice. What you should be doing here is finding your tendon and following it and following it and following it. The trick for you is to keep the tendon in the middle of the screen and be able to follow it all the way till it falls off onto the bone. You see it's getting much broader and flatter now its attachment is pretty close there. It's dipping off underneath the navicular. Yeah, so that's your main skill set. You must be able to keep this tendon in full view all the time. And look how far up I can take it actually. We're right up into the sort of mid third now of the lowish at the tibia, and then we can start to see the muscle belly appearing, and now we're into the actual muscle of it. It's quite high up. Look how high up we've gone here. Several inches from the ankle joint. And coming back down again. Yeah, and similarly, you want to pick all your extensor tendons up and all the slips there, and then you can actually follow them over the dorsum of the foot, and they become broader and flatter. And you're going to pick up your dorsalis pedis artery and etc. Here is the slip, so you can follow those if you're really good, and you go a bit deeper perhaps. You can follow those all the way to the tips of the toes even. We'll keep it around the ankle for today. All right, so then we get our tibant now. We're going to go into long axis. So let's get the tibant in view. And we've twisted our probe. Now we've got the tibant in view. Got a little bit of artifact in the middle because the jelly's drying up. So let me just reapply a little bit for us. Okay, so this is quite a normal looking tendon. You want to see a little bit of black in the top and the bottom of it, and nice striking fibers all the way through it. And underneath that, you can see the tibia, and you can actually see the end of the tibia. You can see here we're dropping off the shelf, and we're straight into the ankle mortise now. So this is your textbook image if you're looking at an ankle examination in long axis. You want to have some tendon, and you have some joint in view too. You can see what you're looking for here is a sort of V shape of the ankle. Yeah, so you can see the end of the tibia on the top of the talar head. Cool image, really cool image. All right, do you want to just lift your ankle up and down for me a little bit? So trying to keep your probe in place and asking the patient to move. And you can see what's happening to the tendon. You can stay on it. And the ankle joint in real time. So if there's an effusion, for example, Adrian, if you flex your ankle for me again, please, you'll see that popping up and over about where the yellow marker is. You'll see it looks like a speech bubble, kind of a speech bubble popping out. You have a little tail coming out from the ankle joint, and then that will be forming a very echo-core area, hypoechoic, black, dark area, which you'll know is fluid then. So really useful for aspirations, of course, brilliant to see because you can just put your needle exactly into it, and they can be a bit tough, ankle aspirations without imaging, I think, because you can just miss that pocket because of course it's a three-dimensional structure. You can just veer off center a little bit and you've completely missed it. All right, so let's just follow a little bit more. So we've got head of the talus, and now we're coming down the talus, so you can see the bone in picture. We've got your tibant in view all the way, and you can see I'm constantly manipulating my probe, moving left to right and up and down just to maintain good image. That's just the way I like to do it. And now you can see the top of the talar navicular joint, which is this little notch. Do you want to just show them the top of the talar navicular? I actually prefer it if the leg's hanging off. You can just get a better overall view, and you can move around medially to laterally on that too. All right, so let's head back up into the ankle. So now we're in the ankle mortise again, and we've got the tendon sitting over the top. We're just going to have a little look around here while we're here, because of course it goes all the way around medially to laterally. So what I'll do is I'll scan a bit more laterally, and the aim here is to keep the ankle joint in the focus. So you can see I'm just following round and having a look inside. You can see a nice black layer of cartilage here. Hyaline cartilage. Looks very, very healthy. Yeah, plenty of collagen in there. And then you can see a bit of retinaculum over the top there, can't you? Just like that. And it kind of just, it always looks a bit grey, so expect it to look this kind of greyish gunmetal grey in there. Interestingly, as I move the probe, can you see little white speckles all the way throughout? Bit deeper, can you see the...
Oh, here.
yeah. That's kind of in the ankle, sitting in the ankle recess, isn't it?
Yeah.
Well, we didn't pick up on anything in the transverse view, did we?
No.
Didn't see any kind of any speckles, so what could just be artifactual, nothing to worry about because the cartilage looks healthy. End of the tibia looks okay. Yeah, so just scanning it across, go from the medial malleolus pretty much to the lateral malleolus, so you get that in view. So now I've got the lateral malleolus right there. I'm just going to keep the ankle mortise in view. There's a bit of a fiddle. It is a bit of a fiddle getting around it. And there you go. Now we're off to the. So I've slipped off slightly there, and we're off to the medial bit. So now onto the medial malleolus in the top of the picture. So that's enough. We've just scanned all the way around and through, and that's a good image. All right. What's the any other structure I need to show them there? I think that'll do for anterior ankle. I want to focus a little bit on the lateral ankle now. So if there's any questions there on that bit, we'll have them now if you want to fire away.
Not got any at the moment. Thank you, Abid. No. Here we go. We've got one request just coming in from Elaine. The Talo navic ligament.
Yes.
Yeah. Yes. Yeah.
Yeah, you can see all the ligaments pretty much. It's just knowing your anatomy.
So if you go to the talonavicular, it's literally just that white band that sits across it. If you go there.
See the sort of
Four hands here.
yeah.
So, from here, across,
All requests coming in as well. So
talonavicular.
You see the fibres in it, and it's kind of a little bit bowed, isn't it? A little bit bowed shaped slightly, because it's slightly humped there, isn't it? That part of your foot.
Yeah.
no.
Oh, now they're going to test us on the organ. Little
Yeah, I actually had a request earlier. I think it was Sue who was worried that she may have missed it because she got cut off. I'm going to try my best to pronounce it. This Sustentaculum tali.
Sustentaculum tali.
That's what I said.
Yeah, yeah. So basically, if you go down to medial, okay, and get the view as you would for the three. So you've got the tib post, you've got the digitorum, and then basically the flexor hallucis, which sits here somewhere. Just find that hallucis behind there. I think that's it. Hold a minute. Sorry, Abid. Let me just find my bearings. Right. So see, right. Hold that there, Abid. So this is the flexor hallucis. This bone here that it sits under is a sustentaculum tali.
Well done, Adrian. Thank you very much. Not much. That's not doable in ultrasonography of the foot and ankle. There's a lot of really interesting structures to get around. Okay, so let's move on to the lateral ankle, or sort of anterior lateral ankle. So for this examination, we're going to look at our three ligaments. So let's start with the ATFL. So if you can. Yes, okay, cool. Here we go.
The anterior tibiofibula.
Oh, the tibiofibula or the talofibula?
Tibia. Ah, sorry. There's me thinking I'm getting clever.
We'll do them both anyway, don't worry.
Sorry.
Okay, so we're going to go in the transverse view. Okay, so we're going to follow our tibia. We're going to find our fibula. Sorry, kind of go to the tip of it, right to the bottom corner of it. And for this exam, you pretty much are perpendicular with the sole of the foot. So on the run, let's get some malleolus in the picture. So I've just got the bone in view here. This is where it gets interesting. I might just let's just get you in view there. Can you just do it? That's
Yeah, you tell me what you want.
Thank you. Yeah, it's just a bit different for everyone, but here we go, guys. So, tip of the malleolus. Do you want to just point that out for everyone for me, Adrian? Please. Okay, so that is your lateral malleolus, the tip of it. Okay, so you get that into the view first, and here, right over it, and between that and the head of the talus, which is the other bone in the picture. And again, guys, it's just, you really got to know your anatomy. And this is the Cfl ligament here, as Adrian's pointing out. Interestingly, can you see it's not right? Yeah, so you can see.
Your
Anyone wants to call it? Any suggestions on what we're looking at here?
Let's give everyone a moment, see if they can come in with an answer, because I know the answer, of course.
Paola should know. We've gone over that enough times.
Right, so let's see. There's a prize for the first person to text it to me.
So yeah, interesting features. If we just talk it through, we can see the fibula end looks fairly normal. Do you want to just highlight that for them?
We've got two different suggestions. Do you want to hear?
Okay.
Oh, we've got 3. They're coming in now.
Oh, good. Interactivity.
Don't give us the answer till I give you all 3 choices.
Okay.
Nodule, avulsion fracture, collagen buildup. Actually, now we've got a 4th coming in at the last second, fibroma.
Ooh.
Avulsion fragment. I think we've got an avulsion fragment and an avulsion fracture.
Okay.
Avulsion.
All good calls, really. I won't say any of them are negative. Let's just reason it through. Let's just talk it through. So if we look at the proximal end, where the yellow arrow is, I think you can just about make out some.
Someone just put I lost me marbles or something.
That's where they've been all this time, right? That makes sense, yeah. So we can see fairly normal ligament at this sort of proximal end, the end to where the red dot is. And then in the middle, we're kind of losing the tendon picture, the ligament, fibers a little bit, and they're kind of replaced by these roundish, bright, hyper-echoic shapes. And then you can still see ligament there, though, and then it's kind of thickened towards the more distal end. Yeah, so it looks like we've got an intact ligament. It doesn't seem to be in pieces. It doesn't seem to be frayed, but it does seem to be thickened, and it seems to have. I would probably call that calcific changes, or calcium deposits. Yeah. So whoever said avulsion, it could have been that there was a previous tear or injury here, and then it's just laid down some calcium when it's healed. Yeah, and so you can see that it was likely a previous injury. Is it symptomatic now? Do you have any pain or any problems, instability or anything?
No, none whatsoever.
Yeah, nothing to worry. So we can press the fib a little bit, and it looks nice and intact. You see, I'm doing a bit of draw test on it, and trying to keep the probe in place. Yeah, so it's stretching with it. Yeah, so it's not coming apart, and it looks attached. So, okay, do you want to give us a diagnosis there, please, Adrian? How would you report that in your world?
Yeah, so I mean, I would call this sort of, calcific deposits within the ATFL.
How about measuring it out? Would you measure that out?
Yeah, I'd measure them and say how big they are. If it was an avulsion, I'd expect this to be a bit more irregular down here, maybe. Could possibly be, but I'd report those as just calcific deposits within the ligament, previous injury, perhaps. I know. Well, no, I did it. I went over a style, and I missed the style and went further to the ground.
Yeah, typical story. Yeah, but it doesn't look like he'd. Well, he probably did partially rupture it maybe at the time.
I did hear a big crack, and then the next several hours it was like a tennis ball.
Now I'm just heading up a little bit. I'll just kind of not talk you through it, but I just wanted to quickly show you. This is the ATIFL, so the Anterior Inferior Talo Tibiofibula Ligament. So you can see that spanning across. How did I get there? Well, I kept my probe on the tip of the malleolus. Yeah, so I'm perpendicular with the floor essentially here. And then I've kept the medial side on the fibula. And all I'm doing is I'm rotating, I'm clock facing. So I'm going from 9 o'clock on the left side of my probe to 10 o'clock, 11 o'clock. About 11 o'clock-ish, you're going to hit the ligament. So this looks more hypoechoic, doesn't it, compared with the ATFL? It's just a different angle, and just so you're picking up a bit of the muscle belly there of the extensor ditch.
Yeah.
How cool is that? Yeah, really nice sonographic image. So that's what you're looking for. All right, spanning across, you can see the ligament maintains its thickness and integrity, and it spans across from one bone to the other. So no sign of rupture. That would be what you call a high ankle sprain, if there's any problems with that there. All right, so there's your two most common ligaments. Yes, you've got a bunch more. You've got the posterior ones and a few more about and around. But if you can just learn to pick up the ATFL and the AITFL. Yeah, so let's just recap that. Tip of the malleolus, boom across to the talus. You've got your ATFL, and then looking a little sweep of the probe, quarter of a turn maybe, and you're onto the.
So you're looking for that to disappear, and then you carry on and let the other bone come into view.
Yeah, so that's your talus vanishing, and that's your kind of fibula coming into view. Yeah, so it's real easy. Well, it's easy when you know how, like everything, but yeah, just practice clock facing that around. So nice and simple. Now we're going to look for the. We will on the way. We're going to have a look at the perineal tendons now. I think we probably haven't got very long left. I was wondering if we'd squeeze it all in, but yeah, we've got a few minutes. So let's have a cut. We'll have a look now at the perineal tendons, and as we pass around the perineal tendons, we will end up seeing your CFL. Calcaneofibular ligament. So it's another ligament you really want to have a look in a case of ankle sprain. So for this one.
So I think Hannah's just asked what was the second ligament. So we've got the ATFL,
yeah,
which is the anterior talofibular ligament,
yeah,
and the AITFL, which is the anterior inferior tibiofibular ligament.
Yeah. So one attaches the tibia to the fibula, and the other one attaches the talus to the fibula. All right, let's. Can I get your leg straight?
Yeah, of course.
I'm surprised you kept it up there that one. Just the way I like to do it, because I find I can manipulate around the ankle a bit more. So again, it's similar to the medial ankle. You want to take your probe in a kind of diagonal position. So find the tip of the lateral malleolus again, and then somewhere you've got to draw an imaginary diagonal line between that and the back of your heel bone. So it's about this angle. So here we go. So you can see here we're straight onto the perineal tendons. Adrian will highlight. So you can see there's two distinct shapes here. So you've got brevis being this chunkier one, and longus, brevis being the smaller one, and longus being the bigger, thicker, fatter one. So let's put it. So you pick them up here. You just want to get them in your picture. Once you've got them in the picture, you can go whichever direction you want. So try and keep them in the middle. Bear in mind you've got a really bony ankle here, so I'm just going to apply more jelly to get around the contour of that. So it can be really fiddly with the lateral ankle. So got my malleolus in picture. Now we've got the perineals here. Yeah, kind of sitting like it's like a what we call that, the yin yang sign. Yeah. That's what you're looking for, the yin yang sign. Yeah, so you can see two shapes together. Now I'm going to try and go up the lower leg and try and keep them in view next to the tibia. Yeah, so you can see them right next to the side of the tibia. We're just going to go all the way up. Let's see when they turn into.
So you see how the brevis has already turned into this big muscle here. And there's brevis tendon. If you follow that down, see it's already made into the big muscle here.
Can you make that out, guys?
Yeah, we had a suggestion that it might be the coffee bean rather than the yin yang.
Okay, coffee beans, yeah.
I'm so pleased we're now down to my level.
I'm just trying to get in touch with my inner peace and all that sort of thing. So. Yin Yang's good for me.
Someone's obviously thinking of coffee. Thank you, Angus.
Yeah, so cool picture here. You can see your perineal muscles, belly appearing there, and then you can see the perineal longus. Look how we're having to scooch around the leg because, of course, you just want to veer off to the posterior aspect. You can keep that all in view if you really want, but we're a bit higher than we want to be right now, so let's come back down to the ankle where we're going to focus it. So you've got your lateral malleolus here, you've got your 2 perineal tendons, and we're just going to follow the contour best we can. And now, as I sweep round, what you can see here is your Cfl ligament. So remember I was saying it's like a hammock almost. Sorry, being a bit fiddly here to get this picture. Just relax your ankle for me, please, mate. Thank you, that's a bit easier. All right, and then, so as we course around, your CFL is pretty much vertical here, isn't it? So as you pass around, you can see them 2 separating off, so it's just before that happens. So if you see them separating, you've gone past it a little bit. Let's just get them back in view. Sorry, a bit awkward to get this angle. Okay, so there's your hammock just appearing. You see the ligaments here. So the 2 tendons are absolutely next door to each other in the coffee bean sign. Yeah, and you've got your CFL ligament here. The thing is, everybody's anatomically different, so you're going to have to scout around a little bit because not all of them sit in exactly the same place. But essentially, you'll see this hammock passing underneath as you go over them. Then you'll start to see the 2 tendons separating away as we head down the lateral side of the foot now. So I've pretty much gone perpendicular here. And I can follow the tendon. There's one's dipping off now, so you see that one longest dipping off, that's going down into the arch. I can keep the other one in view, and you can see it going to its attachment at the styloid process. Yeah, so we'll keep that there. Let's spin onto it in long axis. Okay, totally lost it there. So if I've lost it there, the other way to do it is find your styloid process. And then draw yourself an imaginary diagonal line between there and the tip of the malleolus again. And let's see if we can see that in long axis. So I'm going to go right onto the... Oh yeah, there you go. How'd you like them apples? So there's the tip. There's the styloid process, the side of it. And then we've got that lovely tendon picture here. So I've pretty much filled up the screen. Now I can follow this. Messing my arm up a little bit there. As we pass around the malleolus, I'm going to have to contour a little bit. I have to work my way around. You can see it get a bit thicker there because we're picking up the longest now also. And we can stay on that. And be careful, you've got to be careful there that you don't slip off one and onto the other one as I've just done. And if you're interrogating the tendons, you want to kind of do one at a time, but just because we're struggling for time a little bit now, we're going to keep on there. So there we go. On the malleolus. So this is your long axis sign. Keep the full picture in view. You're constantly manipulating. You know, you're never going to have a fully optimized image every second. But of course, once you've got to the area of interest, that's where you spend your time just adjusting and manipulating your probe. Again, I've got quite a bit of pressure on there. You can see if I had too much pressure, well, you've lost your tendon. You can't really see it. So you see as a release, you can see the striking fibers again. Now look, if I put too much pressure, I'm not pressing very hard there. Again, am I, Adrian? Mm-hmm. Yeah, so just around the ankle, you've got to be gentle. You know, hold it more like a pencil. You know, don't press in too much, otherwise you'll just lose a good quality image. And then you've got to get round the back of the ankle bone now. That's a bit fiddly. Yeah, so you just got to contour it. You might lose it at one corner, and as you pass round, you've got to pick it up the other corner. And that is absolute fill. Well, you got it here because they do go wrong about here, don't they? So let's just it can be hard to just get all the way around it in one go. So even as guys that have been in it a while will struggle sometimes. Yeah, and that's just about manoeuvring the ankle then. You know, like I said, we don't normally scan in this position. That's kind of good enough. We'll back up the fibula. We've got our nice Perineal tendon in the picture. Still in long axis. Losing a bit of image, but we can keep the tibia in view. Follow the tendon. Now we're getting lower end of perineal there. You can see some muscle. Tendon's still on the top. And look how high up we can go with it. And you can just start it to show it's turning to muscle now. So you can see the muscle fibers appearing. Quite high up, aren't we? We're losing the kind of bone because we're so deep. You can see the bright white line right at the bottom left-hand corner. And come back down again. Yeah, much better image. Adrian's gone a bit deeper for us, so you can see quite a bit there. Look how high up we've gone with it. Yeah, but obviously we're way away from the ankle. We weren't doing a lower leg examination. I'm back round the perineal, on the perineal longus. Just be careful not to slip off one onto the other. That's the main take-home point when looking at the perineals. And I'm going all the way back to my styloid. All right, so we looked at it in cross-section and we've done transverse axis, haven't we? Yeah, and we looked at it long axis. We looked at the CFL. There, you got your two perineals together. Again, when they tear, it's usually a C-shaped echo pore, sort of C shape in the middle of it. You've got to have a real keen eye. So usually we'd just go and focus in on it. You know, get a nice big picture of it. Find your CFL and see if it's all attached. And that should conclude your ankle examination.
Thank you. Before you put the probe away, I've got a couple of requests from Martin and Elaine, two of our regular contributors. So here we go. Could you highlight the superior perineal and inferior retinaculum, please? Martin, if you got that. And the knot of Henry, please. Made for Arsenal, didn't he?
What was that, sorry?
I didn't get that, Steve.
Say again, Steve.
Knot of Henry, please.
Oh, the knot of Henry, that's on the medial side, where you've got the digitorum and the hallucis that cross over. But you can sort of see it as soon as you go down into the medial aspect and follow that when the two dive. So down. Oh, need the arrow. I can see my finger in. So go down right underneath the arch, and it's down here where they cross over. So it's probably best to go into long section from there. Again, and literally it's where these two cross underneath the medial arch, and you can sort of get sort of rubbing and friction where they cross over. See these two tendons here. So it's of the flexor hallucis and the flexor digitorum as they pass underneath, and where they cross over like a crisscross like that. That's called the knot of Henry.
Yeah.
Here we go. Yeah, where they cross here. See the two coming down here now. Just here. Does that answer the question for you guys?
I think it does. I'll let Elaine come back to me. I've got a couple of questions actually whilst
I've been doing the homework today. great stuff.
we've had some great input this evening.
Absolutely.
One from Sean, always good to see Sean. Could you see a snapping perineal tendon on ultrasound?
You can.
Yeah, definitely, because it should be sitting behind the notch of the fibula, and it's just a bit of a fiddle to do it. But you get them to just rotate the ankle, and you should see it flicking up and over.
Okay, brilliant. Thank you. Yeah, Elaine was happy with that. Thank you. Cheers, Elaine. Okay, next question. How difficult would it be to determine the integrity of a ligament with an acute injury with local inflammation or fluid?
Well, if it's just dark and fluid around it, I mean, you just put as much, you just do some dynamic stress testing, and if it gaps, you can tell the integrity. Some ligaments, it's difficult to do a dynamic stress on it, but if you can dynamically stress the joint where the ligament is, then you should be able to see some sort of gapping or movement of that ligament. I think that's what they're trying to get at.
Okay.
Yeah, then maybe if you'll see a bit more edema around there, and yeah, there'll be a lot of activity, a lot of action around there, especially if you put your colour on there. So it's just picking through it. You've got to just take the images one at a time and try and pick through what you can see, and just call it as you see it.
They don't recommend scanning very acute injuries until at least sort of 48, 72 hours after it's happened, and then you get the full appearances. So, very, very acute, just happened sort of thing. I tend to leave it a bit longer before you start to interpret what's going on.
Okay, thank you. Some questions coming in now, thick and fast. From Sue, how do you differentiate calcific? Oh, the screen's just jumped. Somebody else has asked the question, and I've lost the question. What was gone? How do you differentiate calcification and an avulsion when it usually happens after avulsed sustentation? Charlie, that's that word. I think so.
An avulsion, obviously they're going to have some sort of trauma aspect, and then you're just looking for that sort of bony irregularity with that sort of bony pull off from that bony site. So you can sort of tell the difference there. Calcification will tend to be more rounded, if you like, in appearance within a tendon or ligament. So it's if the bony contour is a bit irregular where it's pulled off from, and you've got this irregular sort of bony fragment, then that's probably more likely avulsion.
And the ossicles, the sissles, that was in the Bible, wasn't it? Ossicles. The ossicles.
Ossicles.
That's it.
Accessory ossicles.
Accessory ossicles. Yeah, well,
we'll make a podiatrist out of you, Steve.
You will.
It's just about knowing where they come, so you can get them in the tib post. You can get them in the perineal as well. So just know where they come from, and then they're usually, just by the bony insertion. So ostnaviculari, I think, and ostibiali, or something like that. They're called.
Alrighty, thank
or
you.
accessory ossicle is just easier.
Okay, thank you. I get found out on these sessions. People come to me for advice and all that. I have no clue what I'm talking about. But there you go. Hopefully they think I'm a nice person, and they'll give me that's all I can hope for. Now, are there any papers on the amount of hypoechoic signal correlating to tenosynovitis, or is there a rule of thumb?
I'm just trying to understand what the question is there. So tenosynovitis, are there any papers?
Hypoechoic signal correlating to?
Well, if the tendon's hyperechoic, I would tend to call that tendinopathy. If there's fluid around the tendon and there's hyperemia, then that's more like a tenosynovitis. If that makes sense. So if the tendon's hyperechoic and it's got hypercongestion within the tendon, I'd call that tendinopathy.
Mm-hmm.
Tenosynovitis is where you've got this sort of thickened fluid around the tendon with sort of hyperemia as well.
All right.
Makes sense. I don't know any specific papers that go into that, but I'm sure they're out there.
Okay. Starting to get some thank yous coming in, but I had another question. Somebody. Yeah. What should we look for to diagnose tendon?
Sorry, last bit I missed. Diagnose
What should we look for to diagnose tendon tear?
tendon tear. So basically, a hyperechoic or even better anechoic defect. So anechoic just means black. And always scan that defect in two planes. So turn the probe 90 degrees, and if that hyperechoic defect is still there when you turn it into the transverse plane, then that's indicative of a tear. And obviously you can move the tendon and see if it gaps, things like that.
Okay, all right. Now, Mark's come back on that point about the papers. So in the view you showed with the, we spelt it wrong, Perineals, there was some hypoechoic signal. Is that normal? I think he's asking, is that normal?
Oh, in which tendon, sorry?
Perineals?
Perennials. Perennials. Okay, just go back.
Mark spelled that wrong, so he's thrown me there. I know a perineal, but I don't know a perineal. So,
just go through the. Just go.
I think we've switched off the screen share.
Oh, have we?
I'm struggling here, guys, because United are drawing 1-1. Right?
Yeah, I knew you were sidetracked this evening, Steve. I was wondering what it was. Now it comes back.
He's not giving the government a hard time. He's sorting out United. So.
Okay. I presume he's maybe talking about that little bit there, maybe. Just answer yes if that's what he's talking about.
Retinaculum, I think he was asking about.
Is that right, Mark?
These little dark areas here.
Can you hear me?
Yeah. Oh, there you go.
Yeah. So when you pull the two, so the perineals come apart. So if you get a view where they come apart, that hyperechoic in there. So is that perfectly normal in there? That hyperechoic signal?
Tubercle, go into the tubercles there.
Yeah. So if where the arrow is, where the anechoic signal is in between the two perineals, is that normal, or would you say that's?
Oh, here.
Yeah. That's just composite shadowing from the border of the tendons. Yeah, remember they kind of branch it going in slightly different directions here, so you get a bit of shadowing off it.
Yeah.
Yeah, so that's normal stuff.
Yeah.
So how do you tell the difference?
Go into long axis, probably. Yeah, just check it in long axis, because if there's any peritendinous fluid, which is what you're looking for really there, you'll see it in the long axis view. So you just got to spin your probe on it, and you just know that it's normal artifact really. Yeah. Okay. Thanks. All right, dude.
We've got more coming in. I'm conscious of the time, chaps. We've got more coming in.
Is it home time?
Okay?
Cool. No, really happy with this. Great interactivity. Thanks for your questions, guys. Much appreciated.
All right, if I carry on, is it?
You're helping us just as much as we're helping you, so it's great stuff. Yeah, if we've got a bit more,
can we?
Love it. Why not?
Can we just scan the posterior talofibula ligament?
Didn't ask for it.
So what, sorry?
Posterior talofibula ligament.
Oh, bloody hell.
Oh, you had a tough one. What have you done?
I don't know. I don't really look for that. What do you reckon, Andrew? I'll be guided by you.
Thank you, Anna. Nice to see you. Good comments coming in as we go.
So it's just basically going back in that direction.
So we're going to get the fibula in view.
Yeah.
I'm going to scan. I'm going to get some more jelly for this one. Yeah, it's kind of down that way, isn't it? Yeah, I remember that. Testing my anatomy. Okay, so get the tibial malleolus.
So you've got to get fibula, so just find the fibula. So it should be. I think that's a retinaculum. So let's see if now.
Bit too low for it, maybe.
So there's.
It's a fiddle, because it's. Do you want to just relax your foot? I might be able to get a bit more probe action there.
You don't. I don't think it's looked at very often, but I mean, I've seen it being looked at, but it comes back from the fibula and obviously goes down to the tibia.
Yeah, it's really hard to get
There we go. There's a little bit of it there, I think. Yeah.
Yeah, a bit deeper. Not there.
Thank you, Angus. Thank you, Emily. Nice to see you both.
But it's not something I've looked for with ultrasound, to be fair. But you can get it, can see it.
Just practice to keep looking at your anatomy textbooks and keep searching for them.
One more request, if I may, please.
That's it there. Look, yeah.
I'll make it the last one, as it's from.
There you go. There you go, Steve. There's it. Is that Paolo asking for that?
Oh, yeah, Paolo's got that one. Yeah, great. Thank you. You're
You see the angle that I'm at, just so with Adrian's camera. So I've come up the malleolus about, so I'm not on the tip, I'm sort of just about half a centimetre higher up. Yeah, and I'm angling sort of diagonally to the back of the sort of tendon. I'm just about picking it up there. I'm putting quite a bit of pressure in there to get the penetration to get to.
Would a hockey probe make that easier, as an example?
Might be a bit more tricky sometimes.
Yeah,
I think,
you see,
you've got less footprint.
Yeah, you need a bit more footprint, but going round the ankle, the hockey stick's quite beneficial. But
yeah, you just lose sort of image. So you've got to do a lot more work to get to interrogate everything. Whereas with a 9L or whatever, you can see a lot more in one go.
Yeah, getting it quite well out there.
So I've got one more request, and I will make it the last one, I promise, but it's from Martin, so I really would love us to fit in because he's been a regular contributor right since the spring. Never did get to see those perineal retiniculars.
We did that, didn't we?
The retinaculum. So, yeah, if you go back towards where it's the bone, so here we go. Go back again, go down. So there you are. So that's that dark band coming across here. There you go. That's the retinaculum.
Just so we're clear, that prize we did earlier, that quiz we did earlier, there wasn't a clear winner, so there's not going to be a prize given. Shame. Shame, it's going to be a free scanner, but there you go. Mind, you'll all have to do your homework for next time.